Yeah, good afternoon. Welcome to Providence Grand Rounds. The topic for today is application of the new WHO classification of CNS tumors and targeted treatment approaches in neuro-oncology. The two presenters are Dr. Kaimaktchiev and Dr. Smith-Cohn. Next slide. These are the meeting logistics. All attendees are muted in this environment. Please use the Q&A box to ask questions and share comments throughout the presentation. This presentation is being recorded and will be posted on the Grand Rounds caregiver site as well, and together with previous Grand Rounds are also available there. Next slide. There will be CME awarded for this session. Please note the number 225463. And there's also nursing and pharmacy CMEs. Next slide. The planners and faculty have no financial relationships to declare. Next slide. The learning objectives are participants will be able to describe the main changes to the new WHO classification, the future developments in the WHO classification, learn the current state of targeted therapy for primary CNS tumors, and opportunities in personalized therapy of primary CNS tumors. Dr. Kaimaktchiev graduated from the medical school of Sofia in Bulgaria and did some training in France and Italy before coming to Oregon Health Science University to do his residency in pathology and as well as a fellowship in neuropathology. He is a staff pathologist with the Providence, Oregon. Dr. Smith-Cohn did his undergrad, got his bachelor's degree from Alfred University in New York, followed by medical school at Lake Erie College of Osteopathic Medicine in Pennsylvania. He did a residency in neurology at University of Utah and a fellowship at the joint program of Johns Hopkins and NIH. And he's on staff at the Neuroscience Institute in Seattle. Next slide. And I'll pass to Patrick Foley for the reflection.
Thank you, Dr. Chong. Can I have the next slide? So before we begin, which I think is a very relevant topic, and thank you to our presenters for being part of our Perspectives in Precision Medicine program. I wanted to just kind of review where we've been and where we are now. So this is a very simple slide, oversimplification, but sometimes simply putting something forward can be instructive. So on the left-hand side of the slide here, you see Rokitansky's Pathological Anatomy, 2 books, 4 volumes, published in 1855. Karl Rokitansky was a pathologist who did mostly autopsy pathology and is credited for doing over 30,000 autopsies. He was a master of using his naked eyes and hands to learn about disease. But as you see in the middle part of this slide is a black and brass microscope. And we learned that disease can be taken down to the cellular level. Rudolf Virchow was a master at this, and in the ensuing decades in the 20th century, we developed better and better microscopes, transmission electron microscopes, scanning electron microscopes, confocal microscopes, and that's how we knew disease. And what we're going to talk about today is illustrated here just in another text on the right-hand side, Diagnostic Pathology and Molecular Oncology. So we've gotten to the point now where we know disease at the molecular level. And we use it in diagnosis, and we also use it in treatment. And I think our 2 speakers today are going to both present from their points of view how we use molecular information to treat our patients. And I think over the course of roughly a little less than 200 years, we've made some significant progress from using our naked eye and learning about disease that way to now looking at the alphabet of life, essentially, and looking at things on a molecular level, as we've all gone through with COVID, and we know that variants are defined by the molecular changes. So I think that with that as a foundation, you'll find what we're going to talk about today very interesting and hopefully instructive.
It's a very difficult topic. And we only have about 25 minutes. So I'm going to just quickly go over the new WHO classification of the CNS tumors, the 5th edition, which was just published, and it's available now. And then in the second half, Dr. Cohn-Smith will talk about some targeted treatment approaches in gliomas. So this is the Hood River Hospital. I'm mostly located there, and the mountain on the backside is Mount Adams in Washington. Just some objectives. Again, I will present the main changes with the introduction of the new WHO 5th edition of the CNS tumors. I'll give you some examples of our daily clinical practice and maybe some future developments if we have time. So brain cancer is not that common, even though I see it every day. Roughly, it's between 7, 8 to 12 cases per 100,000. However, the mortality is still quite high, so we have a lot of work to do. On the right side, these are all primary brain tumors, of which the majority, 70%, are benign, and about 30% are malignant. Of the malignant one, the most common one is the dreadful glioblastoma multiforme, and then some other gliomas, and including also the primary CNS lymphoma. Of the non-malignant one, the vast majority are meningiomas, some pituitary adenomas, and some other schwannomas and more benign tumors. So again, 70% malignant, 30%. 70% benign and 30% malignant. The majority of the tumors that we see in our practice are older patients in their 60s and 70s. So the median age for all primary brain tumor diagnosis is about 59 years. If you exclude in pediatric population from 0 to 14 years of age, this is the most common cancer, and also the most, the leading cause of cancer-related deaths in peds, even more so than acute leukemia. So the classification of the CNS tumors dates back from the first one was done by 2 neurosurgeons, Bailey and Cushing, and they were the first one to introduce the term glioblastoma multiforme. The first WHO was published in 1979, and now we have the latest 5th edition. And up until 2007, everything was pretty much being done under the microscope, so morphology was the key. In 2008, 2009, with the discovery of the IDH mutation in gliomas, became the kind of the molecular era. And with the previous edition of the WHO, the 4th edition in 2016, for the first time, we had integration of morphology with molecular features. So here's that paper in which IDH mutation was first found in glioblastoma multiforme. Subsequently, it was found in, actually with much higher frequency in diffuse gliomas and especially astrocytoma. 70 to 80% of diffuse astros have IDH mutation, and these are predominantly IDH1 mutation and less often IDH2 mutations. Oligodendrogliomas, now we know that have to have 100% IDH mutation. And glioblastomas actually have a lower number of IDH mutation. And it was also shown that the IDH mutant glioblastoma have a much better survival as opposed to the classic IDH wild type glioblastoma. So now we know why some patients diagnosed with glioblastoma survive much longer. So again, up to 2007, everything was microscope. As of 2016, we have integration of microscope and molecular findings. So 4 molecular entities were introduced in the WHO, the previous edition in 2016. This was the IDH mutation status, the chromosome 1p19q codeletion in oligodendrogliomas, the discovery of H3K27M mutation in diffuse midline glioma, the DIPG tumor, and then the supratentorial RELA fusion positive ependymoma. So that approach of the integrated diagnosis was introduced at that time, which means that first we start with histologic classification, then we do stains, we try to get to a WHO grading the tumor, then we combine all the molecular data, and that feeds back into a final integrated diagnosis. So that's the layered approach. So from 2016 up until now, the latest 5th edition, again, it's published, it's available. There were several updates, actually 7 of them, created by the leaders in the field. It's called C-Impact Now. C-Impact stands for Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy, not officially WHO. So these were updates that were published regularly, and once they were accepted, the WHO 5th edition was kind of issued, and it made it a lot easier for us to understand because it was gradually introduced all these changes to us. So here's how we work up a case, typical primary brain tumor in our practice. You start with the H&E, and then if it's a primary glioma, we ordered immediately that 7 immunohistochemical stains. We call it the IHC glioma panel. And then almost simultaneously, we ordered NGS panel, which currently we have 523 genes. So we sequence actually all of the primary brain tumors, 100%. The vast majority of the meningiomas, especially if they have any atypical features. And we also sequence almost all of the metastatic brain tumors as well. So here's a typical workup. So we have a diffuse glioma, and with 3 immunohistochemical stain, we can stratify and call it astro versus oligodendroglioma, even before 1p19q results. So with IDH1 stain, we know that these tumors will be IDH1 most often mutated. So both astro and oligodendroglioma have IDH1 mutation. The stain stains the mutant protein. So when it's staining, that means presence of IDH mutation. Same with p53. If we have over 10% of positive cells, we call it positive. So that usually corresponds to p53 mutation. And then the ATRX is the opposite. Once we have a loss of staining, that usually means presence of mutation. So that pattern tells us this is an astrocytic neoplasm. If we have IDH mutation, absence of p53 mutation, and absence of ATRX mutation, that usually stands for oligodendroglioma. So we just, these 3 stains, we can pretty good classify them into oligo versus astro. And that takes about, less than 24 hours. So here's a classic case of oligodendroglioma. You can see calcifications and on a high power. The classic morphology, the cells with round nuclear contours and perinuclear clearing, the fried egg appearance, and on the background, chicken wire, fine vasculature, ATRX is retained. So no loss of expression, meaning no ATRX mutation. P53 is negative, meaning no P53 mutation. And IDH1 stains the mutant protein, presence of IDH1 mutation. So this is oligodendroglioma based on morphology, most likely grade 2. So again, how do we integrate the diagnosis? We start with microscopy, we continue to next generation sequencing, and if all the results match, we issue final integrated diagnosis. NGS gives us a lot of data, and sometimes the findings are unexpected, and if we cannot come up to a diagnosis, if the results don't make a lot of sense, we have the option of this methylation profiling, which is currently being offered in very few places in the US, but it's probably the way we're going to go. Okay, so our assay, again, 523 genes, usually small variants, and also looks at some fusions, and the report also will give you tumor mutational burden and MSI. This is an ideal scenario. It's quite laborious process, so it takes at least a week, up to 7 calendar days if everything is okay. As you can imagine, it takes a lot of time, and a lot of personnel are involved with all these steps. So that's the ideal scenario. So going back to the changes in the CNS5, the changes are into the CNS tumor taxonomy, nomenclature, tumor grading. Luckily, with the new WHO, we have the option of using NOS and NEC. NOS is not otherwise specified. For example, if you have a small biopsy, which is not entirely uncommon, especially for brain tumors, and if we don't have enough tumor tissue, not enough tumor DNA, we cannot perform the tests. So we can use, we can say NOS and maybe request additional tissue. Or you can use NEC, not elsewhere classified, if the results that we're getting do not give us final diagnosis. We can say NEC, maybe convert to send it for an outside consult, maybe request DNA methylation profiling. And there's also quite a few new entities. Probably the biggest change in the 5th edition is separation of the adult versus pediatric gliomas. That's being done with this edition for the first time, and this is good because they are. I mean, we knew that they're different. They're different tumors biologically. They're very different tumors with different molecular pathways. And further, pediatric gliomas are separated into diffuse low-grade and diffuse high-grade gliomas. So in a way, the adult type diffuse gliomas, there are only three types. From 2016, there were 15 or 16. They went to a much simpler, versus the pediatric expanded quite a bit. We have 14 newly recognized gliomas and glioneuronal tumors, and I highlighted just a few of those. Here's these plenty tumor polymorphous low-grade neuroepithelial tumor of young. We have diffuse hemispheric glioma H3G34 mutant. These are high-grade astrocytic gliomas in pediatric population. The ependymoma now are divided into their anatomical location. So we have supratentorial ependymoma, posterior fossa, and spinal ependymomas. And the previously RELA fusion positive ependymoma, now it's called ZFTA fusion positive after the other fusion partner. Okay, and we have 8 new other tumors. These are mostly embryonal tumors. I'm not going to have time to go over all of these, just so that you can see. So briefly, the plenty tumor, the polymorphous low-grade neuroepithelial tumor of young, it looks like an oligodendroglioma, but it's a grade 1 tumor, and it doesn't have IDH mutation, and there's no 1p19q codeletion. Usually, teenagers with refractory epilepsy, and again, they have a different molecular alterations, mostly involving the MAP kinase, BRAF V600E, and FGFR fusions like FGFR TAC3 fusion is being a common one. Another interesting tumor is that diffuse hemispheric glioma H3G34 mutant. As a matter of fact, I think we just have one of these cases today. It's a high-grade neoplasm. It looks like a glioblastoma, but it can look as an anaplastic astrocytoma or even peanut-like small blue cell embryonal type tumor. Usually affects adolescents and young adults. Its GFAP can be positive or negative. OLIG2 is usually negative, and they have very frequently P53 mutation and ATRX mutation. So it's very specific molecular profile. So with the new WHO, we're going to use the Arabic versus Roman numerals just to stay consistent with the other WHO books. There's grading within tumor types. For example, astrocytoma IDH mutant goes from grade 2 to grade 4. There's no more IDH mutant glioblastoma, and there's no more use of the term anaplastic. And there's still clinical pathological grading, so it's not strictly histopathological grade. We're saving ourselves with more of a clinical pathological grade. And again, if we can not give a grade in situation in which the information doesn't make sense. So, for example, you have a low-grade tumor, and then you find molecularly some alterations, for example, third promoter mutation, and all of a sudden, well, how do I call it grade 1? you have a tumor with third promoter mutation. So in this case, we can just put this in the comment explaining the findings that it doesn't make that they don't make perfect sense. So to avoid confusion, we're sparing the grade in this type of cases. So here's a case from our clinical practice. 40-year-old woman with left frontal tumor, looks like a primary glioneoplasm, mild enhancement and midline shift. Under the microscope, diffusely infiltrating glioneoplasm. There's only one mitotic figure that you can see with the arrow. High power view. There's an astrocytic look. The cells have oval but irregular, a bit irregular nuclear contours and very coarse chromatin. There's no necrosis, no microvascular hyperplasia, so it doesn't look particularly anaplastic. And also you can see on the background just entrapped axon, so that tells us that this is a diffusely infiltrative tumor. Surprisingly, IDH1 came back negative, but again, she's 40 years old. We have a diffuse infiltrating glioma. We expect the IDH1 to be mutant. And ATRX shows loss of expression, meaning ATRX mutation. So that tells us even more. There has to be a different IDH1 mutation that non-canonical IDH1 mutation that we cannot detect with our immunohistochemical stain. Ki67 for this case was mildly elevated, and P53 was mutant. Positive staining, strong staining indicating probably a P53 mutation. And indeed, NGS did find IDH1 mutation, just a different one. That's why we couldn't detect it with IHC stain. And it also showed ATRX and P53 mutations. So if we follow the guidelines of the C-Impact Update 5 for criteria and grading for IDH mutant astrocytoma, we have to exclude the presence of CDKN2A homozygous deletion in this case. If we have CDKN2A homozygous deletion, this is associated with very poor prognosis, and that can be upgraded to a grade 4 glioma. And here in this paper, it shows that anaplastic grade 3 astrocytoma that's IDH mutant and with homozygous CDKN2A deletion actually behaves worse than glioblastoma that's IDH mutant but wild type for CDKN2A. So there's, again, quite a few changes in the grading system in the new WHO. Astrocytoma, again, goes from grade 2 to grade 4. Oligodendroglioma remains grade 2 and grade 3. There's just no anaplastic oligodendroglioma. Glioblastoma is reserved, the name is reserved only for IDH wild-type tumors, and it's always grade 4. The diffuse hemispheric glioma H3G34 mutant is grade 4. PXA remains grade 2 and grade 3. There is just no more anaplastic PXA. The ependymomas are grade 2 and grade 3. Myxopapillary ependymoma is upgraded. Previously it was grade 1, now it's grade 2. Minor changes to meningiomas. And previously, hemangiopericytoma solitary fibrous tumor. Now it's only called solitary fibrous tumor, just to stay consistent with the soft tissue WHO. So here's a different case from our practice. This is a 58-year-old gentleman with left posterior frontal tumor. Imaging was suspicious for a low-grade glioneoplasm. On H&E, again, diffusely infiltrating, astrocytic-looking tumor. No high-grade features, no necrosis, no microvascular hyperplasia, not a lot of atypia. I don't see mitotic figures. Unfortunately, IDH1 in this case was negative, so IDH wild type. ATRX was retained, so no ATRX mutation. P53 was negative, and Ki67 was mildly elevated. So with IDH wild type and diffuse astrocytic glioma, we are concerned about molecular glioblastoma, or what used to be called molecular glioblastoma. And indeed, here's the NGS on this case. It did show presence of third promoter mutation, and it did show also NF1 and PTEN mutations, which are all common in glioblastoma in primary GBMs. So following the C-Impact now update 3, if you have a diffuse IDH wild type astrocytic glioma grade 2 or grade 3, if you have any of these 3 molecular features, either EGFR amplification or combined whole chromosome 7 gain or 10 loss, or third promoter mutation, any one of those, this is enough to be called glioblastoma. And for a while, this was published in 2018. For about 2 years, we used that term of diffuse astrocytic glioma with molecular features of glioblastoma. We would call it grade 4, and this was confusing to our colleagues, and we had to explain in comments exactly what it means. But anyhow, with the current classification, now this is just this is just consistent with glioblastoma. So any IDH wild type diffuse astrocytic glioma that has microvascular proliferation or necrosis, just by simple morphology, or if you have any one of these three, third promoter mutation or EGFR gene amplification or +7 or -10 chromosome copy number changes, this is enough to be called glioblastoma. Okay. And indeed, this case behaved badly. The tumor behaved like a glioblastoma, and this is a very rapid progression. I think within a month, it grew quite substantially. Just recently, CAP just published a new guidelines how to work up a diffuse glioma, and there's 13 of these recommendations. Some of these are strong and some of these are conditional. I'm not going to go over all of these, but we cover pretty much all of them with very few exceptions. All of this is done in-house. And that's pretty much it. So that's probably the future. It was some of the tumors in the current classification can only be diagnosed with DNA methylation profiling. This is a pioneering work done by the Heidelberg group. So that's the DNA methylation-based classification. Summary, the main changes are separating the adult versus pediatric gliomas. We have 14 new gliomas in glioneuronal tumors, and we have introduction of the DNA methylation-based classification. And thank you for your attention. Happy to answer any questions.
All right. Can you see my presentation screen?
Yes.
Yeah.
All right. Excellent. All right. Well, thank you guys for the opportunity to present. I'm Matthew Smith-Cohn. I'm a staff neuro-oncologist here at the Ivy Brain Tumor Center in Swedish Seattle. And today I'll be discussing targeted treatment approaches in neuro-oncology. I have no disclosures. And so in outlining my talk, I'll be talking about the challenges of targeted therapy in brain and spine tumors. I'll also be providing an overview of personalized molecular treatment in primary CNS tumors, as well as future directions. And so to start with, the most common primary brain tumor in our practice in adult neuro-oncology is glioblastoma. And compared to other cancers, we're a bit behind the curve for various reasons. We have the same standard treatment since 2005, despite dozens of patients enrolled in trials, and which is 6 weeks of concurrent radiation with temozolomide, followed by 6 months of adjuvant temozolomide. And some of the reasons for this is due to the blood-brain barrier and also genetic heterogeneity between patients and the tumor itself. And so one point of emphasis in affecting our field is 90% of FDA-approved drugs do not penetrate the central nervous system, which limits therapy. And one thing to note is that molecules greater than 500 daltons will not cross the blood-brain barrier. For context, temozolomide, the drug we frequently use in our patients, is 194 daltons. Rituximab, which is a monoclonal antibody, a large monoclonal antibody, does not generally cross. And another aspect is many of these drugs get pumped out of the brain. So although you might have a small molecule or it's lipid soluble, it goes through the blood-brain barrier into the brain, but it gets pumped out by these ATP binding cassette transporters, of which there are various subtypes. And then another aspect is that gliomas are a diffuse whole brain disease. You cannot remove it surgically. They tried to do this at Johns Hopkins early 1900s, and it didn't work. And so we have here in this gross pathology slides is that we have a diffuse glioma where you have this gray section be the necrotic region, which is representative of breakdown blood-brain barrier. We also have these black dots, which is representative of tumor cells within these slides here. So as you can see, gliomas can spread throughout the brain, different aspects. So for an effective treatment, you need to hit the cancer cells in all the areas, not just the leaky contrast enhancing aspects. And so what about EGFR mutations? So endothelial growth factor is a common mutation, very characteristic glioblastoma, as indicated by the prior presentations. Most of these tumors do have EGFR mutations, including EGFRB3, and which looked like it could have been a promising target. However, there's been many trials over the years, different small molecule drugs, immunotherapies, and even still some ongoing trials, and has not affected overall survival. And a lot of that's due to these redundant pathways. So although you block EGFR in one way, there's other pathways which you can affect tumor growth, proliferation of cancer cells, et cetera, such as FGFR, PDGFR, et cetera. There's many others in this sort of simplified graphic. So in a lot of ways, we can think about it, different channels into a river. So you block one channel and just diverts to another direction, and the tumor keeps growing. And so what if you do have a good therapy that gets through the blood-brain barrier, such as immunotherapy? You have cells that are specific to a certain antigen on the tumor that can get in there and kill those said cancer cells. So rindapepimut was a promising study where we use this vaccine and prime the immune system to attack EGFRB3 mutant gliomas. And the goal of the study was to assess in almost 400 patients whether adding this vaccine to standard chemotherapy would improve survival in EGFRB3 positive glioblastoma. And after 4 different trials, subsequently to the large phase 3 trial, the ACT4, we found that it was a negative study, unfortunately. And when you look at some of that study and then the earlier iterations, you'd see that there was antigen loss in these tumors. And this slide these slides over on the right is showing EGFRB3 stains. On the A is showing it's positive, and the same patient recurrent tumor, it's negative, so there's antigen loss. So these tumors are very tricky to treat, as you can imagine. And then even more challenging with glioblastoma is that if one were to look at different pieces of the tumor, represented here by T1 through 4, there's genetic heterogeneity in this represented patient. So although you might have certain amplification mutations, there's EGFR and one clone, as you go in different aspects of the tumor, they have different driving mutations. So they're more or less, you could be treating one subpopulation in glioblastoma. So, I mean, the overall kind of overarching thing is in most glioblastoma patients, targeting one mutation is probably not going to do the trick the vast majority of the time. One thing that we're doing at the Ivy Brain Tumor Center, the lab over here, they've been working on it for quite a while now, is that they've been taking patient tissue, fresh tissue, culturing cancer stem cells, and using this high throughput drug assay with dozens of FDA-approved drugs to see if certain combinations could affect these stem cancer cells. There's been an ongoing phase 0-1 study that's near completion. We're hoping to open a new trial here in newly diagnosed glioblastoma patients. So the thought is, if you can target multiple pathways, perhaps a combination of 3 different drugs, you can affect these subpopulations, especially within the stem cells, which are not differentiated just yet. And here's a transition to a different case. Here is a progressive, what was thought to be meningioma. So here's a 20-year-old man who presented with seizures. He had a left parietal mass, and that was resected. It was felt to be a typical grade 2 meningioma. Over the next 8 years, he underwent 6 additional resections, 2 courses of radiation. He had continued progression. And so with an effort to find different treatment approaches, he had molecular analysis. And so he had molecular sequencing done at the National Institutes of Health, which found that BRAF V600E mutation, which is not characteristic of a meningioma, which raised some questions. He subsequently had methylation analysis which more or less is using bisulfate sequencing and genomic DNA. And this converts a methylated cytosine to uracil typically, but in methylated cytosine, you don't have that transition uracil, and so you have all sorts of different patterns one can see of certain tumor types. In this case, this patient clustered within pleomorphic xanthorastrocytomas, otherwise known as PXA. So he had a clarification of diagnosis, something completely different. Subsequently, this patient was placed on trial targeting his BRAF mutation with a MEK and BRAF inhibitor study using encorafenib and binimetinib, and he had a fantastic therapeutic response over time, and as far as I know, it's been a sustained response. So you can see here in the top row all this ugly tumor here on the left parietal lobe, and down below he had a great response. And about BRAF a bit more, so it's found BRAF 600E mutations are found about 2/3 of pleomorphic xanthorastrocytomas, about half of gangliogliomas, up to 1/10 of pilocytic astrocytomas, a little bit less frequent in high-grade gliomas and GBM, but it does happen. There's also this fusion mutations, a common one being the KIAA 1549 BRAF fusion mutation. It's found up to 66% of pilocytic astrocytomas and pediatric astrocytic tumors. A little bit less frequent high-grade gliomas, but does happen as well. And so about the pathway of BRAF, it's this RAS-RAF MEK or kinase pathway. So you start at the top, and this is a bit of a simplification, but one can think of, here's the driver mutations, the fusion mutation, the BRAF V600E mutation, and you can block BRAF with dabrafenib, vemurafenib. One caveat though with the fusion mutations is that it does make a heterodimer more or less resistant to the first generation BRAF inhibitors such as vemurafenib. So if you do target these fusion mutations, just monotherapy with BRAF inhibitor, it's not really hitting it, and you're going to have paradoxical activation through CRAF, for instance. But more or less deriving from the melanoma literature in which you have BRAF V600E mutated melanoma, is that if you combine blocking multiple points of the pathway, including BRAF and MEK, you have more sustained responses, better responses overall, since you kind of block aspects of the feedback loop within this pathway to prevent growth. And if you were to look at the National Comprehensive Cancer Network guidelines for low-grade gliomas, after resection, if you have a tumor that's misbehaving, you can see that it's in the guidelines, you can consider BRAF and MEK inhibitor in these BRAF mutant tumors. And, as kind of exemplified here, you can consider combo dabrafenib, trametinib, vemurafenib, kaimaktchiev. So fusion mutation, consider a monotherapy of MEK inhibitor. No one knows quite which combination is best, but there are options. Recently, there's been a great trial looking at dabrafenib and trametinib, a BRAF and MEK inhibitor, and BRAF V600E mutant low-grade and high-grade gliomas. It's called the ROAR trial. So it's a multi-center, open-label, single-arm, phase 2 basket trial. And so they had 45 high-grade patients in this trial. 31 of them were GBM, 13 of them were low-grade gliomas. And in the high-grade glioma cohort, 33% had an objective response rate, which in the field of neuro-oncology is a fantastic thing to see. And by independent review, the median duration response is notably to be over 13 months. In the low-grade glioma cohort, there was over twice as much objective response rate, almost 70%. And notably, the mean duration response by independent review was over 27 months. And the side effects was nothing surprising, typical side effects one would expect with MEK and BRAF inhibitors. And so overall was fairly tolerable. Transitioning to another targeted treatment, as presented in the last talk, there are IDH mutant gliomas. One approach that's been explored among the IDH inhibitors is ivosidenib, which is IDH1 inhibitor. It's used in AML patients. It's used in cholangiocarcinoma as well. It's approved in those circumstances. And so in this trial, published in Journal of Clinical Oncology. It's a multi-center open label phase 1 trial, dose escalation. They had 66 patients enrolled in a non-enhancing glioma, which is indicative of a low-grade IDH mutant astrocytic or oligodendroglioma. Over 85% achieved stable disease with a median progression-free survival of 13.6 months. There wasn't really a big objective response rate seen, but they did. The main takeaway was they did see suggestion of clinical benefit with stability disease. In enhancing disease, however, the median progression-free survival was only 1.4 months. And this was in enhancing disease tends to be the grade 4 or grade 3 tumors, so higher grade. And the thought process behind this kind of lack of response seen in benefit was higher grade tumors tend to be addicted to other metabolic pathways. They have additional driver mutations, such as CDKN2A and B, as previously presented. And more or less, the mechanism of ivosidenib is that if you block, which is also called HE120, if you block the IDH mutation, you don't have these oncometabolites along the Krebs cycle of IDH mutations, is 2-hydroxyglutarate. And so you have more or less normalization of the cells to some degree and stabilization, rather than lysis of the cells like a traditional chemotherapy. And so from that paper, they had some nice representative cases. If you were to, for example, focus on A over here, you have this little nodule tumor left over, and then over time it grew in the screening process. It was this patient started receiving treatment, and you can see shrinking. And if you were to put overlays of different MRIs over time, with the red being the late in the cycle, you can see that the lesion did shrink over time. So you can see the different growth curves of these different IDH mutant gliomas. And they did see a decrease in these growth curves, or in some cases, at least a plateau in the growth, showing stability of disease. And move on to another case. Here we have a 3-year-old with a history of high-grade spinal cord glioma. This patient progressed after 72 weeks of intensive chemotherapy. You can see here the arrow sign indicative of the tumor. This patient was found to have an NTRK gene fusion and was treated appropriately with a targeting agent. And you can see here had a fantastic therapeutic benefit. And so these NTRK mutations is sort of an exciting and new mutation that we're finding all sorts of brain and spine tumors. It is rare though compared to, let's say, some of the breast cancers out there and varieties, but when you do see it, it is a win. And so there was a study recently looking at 33 patients, mostly kids, although it did have a range up to 79-year-old. It had 19 high-grade gliomas and 8 low-grade gliomas, and it used this lorlatinib as therapy, and the overall response rate was about 30% for all the patients. And the one thing you should note is that when we look at response rate, it's by the rheologic assessment neuro-oncology, where you need 25% or more reduction in tumor volume. But if you look at more kind of subtle changes over time, there was 82% of patients had tumor shrinkage. And you can see here just kind of graphically, numerically, but also here on the waterfall plots shown here. And the thing is, at the notably, this point out the 12-month rates for duration response was 75%. So it was a sustained therapeutic response in many of these patients. And one trial we're opening up here at the Ivy Brain Tumor Center at Swedish is looking at a more brain penetrant NTRK inhibitor. So we're looking to open this soon. And as shown in this slide, the thought is, again, in enhancing disease, you have leakiness of blood barrier, and in sort of more classic NTRK inhibitors, you have shrinkage of tumor within those regions, but the non-enhancing disease remains. So the question, with this study that we're opening over here, is that will there be perhaps a greater response rate than the 30%? And so that's one thing we're trying to find out. And another fantastic recent paper released in January this year is CAR T-cell therapy for K27 mutant diffuse midline gliomas. So these tumors are universally fatal. They're a terrible disease affecting kids. They live less than a year. And this was very impressive to see in print. So in one of the cases they had in the paper, it's a 24-year-old woman with a K27 mutant diffuse midline glioma on her spinal cord. And so they used this CAR T-cell immunotherapy targeting this ganglioside, this GD2, which is highly expressed on K27 gliomas. And you can see here, here's baseline. You have this nasty tumor in the thoracic spine. And by day 47, there was dramatic response. The patient was reported to have better ambulation, less symptoms and pain, which was really, for this kind of tumor, is amazing. The one thing though, and more needs to be sorted out, is in some days later, day 75, for instance, in this patient, and then the other patients in the case series had some findings, is that the tumor did come back day 75 in this case. And so there was probably some degree of antigen escape, but this, I think by seeing this kind of illustration, there's more work to be done. And I think there could be some promise in the future with this. And moving on to neurofibromatosis type 1. So this is a phakomatosis, which results in nerve sheath tumors, gliomas, etc. This mutation affects neurofibromin, and it's one of the more common conditions we see. So just a little illustration, let's say a mutation in NF1, which leads to activation here of the pathway we looked at before, the RAS activates RAS, and it leads to gene expression and growth, could lead to gliomas. And then an attractive target, again, is MEK. So you can block MEK with trametinib, selumetinib as options. In fact, there was a phase 2 study that was performed on 25 pediatric NF1 patients where they used selumetinib, and they saw a partial response of 40% in stable disease and over half the patients. And here's a little waterfall plot here. And here's an excellent responder from that report. So you can see here a patient before treatment, and as they gone through treatment, this surgically inaccessible tumor, I mean, this is not a tumor you're going to remove all of, had a fantastic therapeutic response. You can see just this, it looks like just a really great response here. And in tuberous sclerosis, another phakomatosis, we have options as well. So here we have a 12-year-old that had refractory seizures, developmental delay, etc. And you can see this subependymal giant cell astrocytoma, which really isn't an astrocytic tumor, it's more of a glioneuronal tumor. Underneath the microscope, it looks more or less like the subependymal nodules you might see in other aspects, parts of the brain of tuberous sclerosis. And then when thinking about the biology of tuberous sclerosis, here's a general pathway. In these patients, you have mutations in TSC1 and 2, and which leads to downstream growth of different pathways, protein synthesis. An attractive target, though, we have is mTOR. And so we do have a drug for that, and that drug is everolimus. And so if we treat these patients with everolimus, you can sometimes see a nice treatment response. So in this case, this patient had a 57% reduction in tumor volume. And so everolimus is not only used for tumors, but can also decrease seizure frequency in these patients. In fact, in tuberous sclerosis, going on and discussing more of the tumor reduction, there was a study looking at over 100 patients, and of the patients, had 35% of them had a 50% reduction in their tumor size. And there was a 2012 Lancet study that looked at a series of patients, and there was a durability even 60 months out with everolimus with shrinking of these tumors. And meningiomas, so meningiomas are tumors of the covering the brain, not within the brain itself. If one were to read modern literature about it, you'd see oftentimes in the introduction, there's a statement, there's no known effective medical treatment for meningiomas. I mean, we try all sorts of different treatments with Avastin, octreotide, et cetera, but there's not really a known therapeutic option. So in meningiomas where radiation and surgery aren't doing the job, there is an ongoing clinical trial through Alliance Oncology, which we opened a couple months ago here at Swedish as well. And so it is a personalized kind of trial where we look at individuals' unique mutations within their tumor itself. And if they have a qualifying driver mutation, we have a personalized targeted treatment approach we can try in these patients. And so this trial has been ongoing for years, and we're happy part of it. And so that's another thing we're interested in seeing in the future, if a subset of these patients could benefit from targeted therapy. And so kind of future directions to kind of summarize with therapy of brain and spinal tumor patients or targeted therapies is we need better drugs that get into the central nervous system, since most don't. And we probably need to find drug combinations that overcome redundant growth pathways and do so in a way where there's not too many side effects. And then there's some interesting work on the horizon with synthetic lethality. So in brief, synthetic lethality more or less is if you have a certain mutation in a tumor and it's reliant on a normal and active gene within the cell. And if you turn off that normal gene, you lead to synthetic lethality because the mutated gene is not working. So if you kind of hit more or less that healthy gene, you can kill cancer cells. And there's been look into that with PARP inhibitors and low-dose temozolomide with the adult brain tumor consortium trials in mutant gliomas, for example. We definitely need robust molecular markers and good patient selection for these trials. The old trials in gliomas just hit all the tumors, the same chemo, and as we're hopefully showing with these talks is that there's different molecular subtypes and variations going on. And then with these rare tumors and then even more rare mutations, we need multi-institutional trial collaboration so we can get some data and help move the needle forward. So I just want to thank everyone for your attention and participating today. And I also want to point out here in Seattle, we have our big brain cancer walk coming May 1st. And it's a big group that goes there, and I have not participated yet, but I heard it's a fantastic time, and all donations go to research. I want to thank everyone.
Okay, thank you, Dr. Kaimaktchiev and Smith-Cohn for two very interesting talks. And I think we have one question in the Q&A. I think the question is there any risk factors to development of glioblastoma? A question was, they had a relative that was exposed to Agent Orange. Would that be considered a risk factor?
Agent Orange is not known to be a risk factor as of yet. There is all sorts of research going on with environmental factors, and the one we know is high doses of radiation. So you see sometimes in people who had pediatric cancer, such as leukemia, where they had brain radiation as a kid, they might be predisposed to glioblastoma later on. There are certain genetic syndromes like neurofibromatosis type 1 and Lee-Fraumeni syndrome, for instance, that were predisposed to glioblastoma. By large, though, most of glioblastomas are sporadic without a known environmental cause, although there is ongoing research into that to see if there are signals. But yes, cell phones don't do that. They tortured rodents with cell phone signals and did not see increased brain tumors in rodents, for example. So yeah, but Agent Orange, no data as of yet.
Okay. The second question from Dr. Takasumi. Would Dr. Kaimaktchiev please speak about how he uses Oligo-2 in his initial workup of glioma?
What's the question exactly? The Olig-2 immunohistochemical stain?
I think it's probably a stain, Olig-2. So you can see in your Q&A.
Okay. Oh yeah. Okay. Yeah. So Olig-2 is an immunohistochemical stain which highlights glial cells. So it's part of our glioma, IHC panel. For example, why we use Olig-2? If we have, so not every glioma stains with Olig-2. The classic example would be Meningiomas. They do not stain with Olig-2, and some other, epithelial glioblastoma sometimes can lose Olig-2. So not every single glioma can stain with Olig-2. It's just part of the entire panel. We looked at, GFAP staining, we looked at vimentin staining, Olig-2, and the whole thing taken together gives us a better idea of what the tumor, would look like. Does that make sense? So it's just part of the glioma panel.
Okay. Another question. Patrick Foley had a question about, since most drugs do not cross the blood-brain barrier, how about making it more permeable?
Yeah, so there's a lot of research going into that. If you were to open the blood-brain barrier, you need to open all of it. As shown in that slide earlier, gliomas are diffuse diseases. There's been attempts of intraarterial approaches, ultrasound, etc. There's exploration of basal-active peptides, which is one trial being done over at Hopkins with regadenoson, for instance. But yeah, either we need better drugs that are more lipophilic and don't get pumped out by the drug pumps, or think about ways to open the blood-brain barrier transiently. But yeah, there's a lot of research going on with that.
I have one last question for Dr. Kaimaktchiev. So for the non-neuropathology pathologists, what would be the role? Because since the criteria we were trained to diagnose GBM, vascular proliferation, necrosis, now probably do not make it a GBM. So what would be the role? Say during a frozen section, do we still make a diagnosis? Or do we just say there's enough tissue, send it to the experts?
So a lot of general pathologists can diagnose these tumors, and in our practice, any one of the 25 pathologists can get a brain frozen section. So if you know the images, if you see clearly necrosis and high-grade tumor with necrosis, yeah, maybe you can call it glioblastoma. We try to not commit on the frozen if you can, because again, sometimes you can have just a glial neoplasm that looks very low grade, but ultimately you may find molecularly that it's actually going to behave like a glioblastoma. So it's enough, and I think we've communicated with the neurosurgeon and they know that. So in practice, it's more importantly to just tell them that we have obtained diagnostic tissue that we can work up with, and that's good enough. If you can commit to a glioblastoma, sure, by all means call it, but you don't have to.
Yeah, I agree. And I recall a case a couple months ago where the frozen was likely GBM, the images look like GBM, but it turned out to be toxoplasmosis. So there's caveats with that. And as a neuro-oncologist, my preference is to have that final pathology, because if you're talking about radiation and chemo and they have a brain infection, it's a whole different approach there.
Okay, thank you, panelists. We've come to the end of our hour, so thank you for your presentations and to those who attended this CME talk. Thank you.